Hello, hi, welcome everyone to our conversation that starts with a question. Is the ICU or the ER right for you? I'm Jenna Pope Martinez. I am the Clinical Engagement Advisor at Tallahassee Memorial Healthcare, and I'll be the host for today. This conversation is held by TMH because it's an important one. Choosing a nursing field is a topic that we discuss often in the hospital hallways and school classrooms when we talk to students. Emergency and critical care are among the most highly specialized, highly sought after fields in nursing. Both departments share similarities, but we all know that they differ in the patients that they serve, the care they provide, the nurses that they produce. More and more, we see students split between the two. Nursing managers and new graduates are having this conversation as they interview. I see it every day, and they're split whenever they receive offers and they start their careers. So we already know that you're making a ton of decisions as you enter the nursing profession, and we want to offer you some insight as you decide between the ICU, the ER, or a step-down unit to help guide you on the best path for a long and successful career. I am just the host. We have two experts with us today. We're going to be fielding questions throughout, so feel free to ask them in the chat or in the Q&A box. Joining us today are a couple of TMH nursing leaders who started as new nurses in their areas and then came to manage those departments. Kyrie, would you like to introduce yourself?
Sure. So my name is Kyrie Thomas. I'm the Assistant Chief Nursing Officer at TMH. I've been in this role for about a year now. Currently, I oversee all of the adult inpatient, acute care units, critical care, and ER. Prior to this role, I was the Executive Director of the Emergency Department, which oversaw Bixler Emergency and Trauma Department, the freestanding Northeast Emergency Department, the ED Observation Unit. We also have trauma, EMS, and the transfer center. I'd started as a new grad in the ER, so I can speak very frankly about the experiences that I've had there. I graduated in 2009 from Florida A&M University, started in the ER shortly thereafter, and kind of worked my way up to charge nurse, assistant nurse manager, director before going into the executive director role. So I've kind of been all over that role.
And I'm Suzanne. I'm the Director of Critical Care Operations. Our department covers the cardiovascular medical surgical ICU, the neurotrauma ICU, and the neurocardiac intermediate care unit. I graduated from Kaiser in 2017. I started in the cardiac ICU, so I can also tell you what it's like to start in the ICU. I worked as a preceptor, charge nurse. I worked as an educator, assistant nurse manager. I also worked as an assistant nurse manager in the neurotrauma ICU, and then as the Director of Critical Care.
All right, thank you. First things first, right? Before we can kind of discuss how these departments are different, we kind of have to define them. Can you describe the emergency and critical care departments first and kind of their breadth and what's encompassed in each of them?
Yeah, I can start. So on the 5th floor, we have our neurocardiac intermediate care unit. This is exactly what it says, an intermediate care unit. We see patients that are leaving the ICU, but not quite ready for med-surg. They see drips such as like cardine, Precedex, patients on BiPAPs. They have a 1-to-3 ratio. And then we have our Bachler Neurotrauma ICU. And exactly as it sounds, we see our stroke and trauma patients mainly on this floor. And then CVMS ICU, where all things cardiac and a lot of your surgical patients go.
From an ER standpoint, so Bixler is the main emergency department. It's the one that's attached to the hospital. It also houses the trauma center. The Emergency Center Northeast is the freestanding emergency department that's off of Thomasville Road over there by I-10. And then we have the ED Observation Unit, which is a 12-bed unit that we use for patients that aren't really sick enough that they need to be admitted in the hospital, but they need longer than an emergency stay. So patients like that need blood transfusions, or they might need an MRI the next day, things like that are more quick turnaround times. So we don't have to do all of the hullabaloo of getting them into the hospital. And they should be gone within 24 hours. So it's still acute care, but quicker.
Cool. Thanks, that's helpful. Kyrie, you mentioned the trauma center. So TMH is the region's only level 2 trauma center. TMH is also a Joint Commission Comprehensive Stroke Center, accredited chest pain center. Can you discuss kind of what that means logistically in terms of the operations, the regional impact, patient volume, the level of care?
From an ED standpoint, it means a lot. So typically, like if you're working in a more urban area, Atlanta, for example, or Dallas, where there's multiple hospitals and multiple emergency departments, they typically have a specialty, right? So usually one is more geared towards cardiac, one is usually the trauma center, one is more geared towards stroke. So they kind of make that their specialty that they care for. In our situation, we're not in a situation where we have other big centers around us, right? And so we become that primary center for all of those things. So it does mean that we have to have more education typically than normal. We do a little more training than I would say is normal in the ED. We have a longer orientation period. We have orientation to the trauma bay and certain critical care drip type things so that we can try to make sure people are prepared for that. Because you do have to be a little more, have a wider breadth of knowledge to be able to do all of those things in one area. We serve a wide area also. So we're taking patients from probably, I think it's roughly 20 counties up into Georgia, across the state. And so when we're talking about these types of rural areas and settings around us that don't have the acuity or the level of healthcare that we provide, then we are the hub to take all those patients in. For Leon County alone, we take about 2/3 of the EMS volume. So it's a lot. We treat at Bixler, they are seeing over 65,000 patients a year. I think Northeast is over 40. So combined, we're seeing over 100,000 patients a year. Northeast is more geared towards pediatric patients, typically not those alert type patients, right? So not your stroke alerts, not your trauma alerts, but your general emergency patients. So abdominal pains with unknown source of origin, chest pain patients, that type of thing is what their bread and butter is.
That's a lot. Suzanne, can you kind of speak to what that means for your units that you oversee?
Well, for our units, I think it's that we get to work with the best of the best, and we get to provide the best care possible to our community. Having and maintaining these titles takes a tremendous amount of work and support, and we have just that. For our stroke team, we have navigators, managers, improvement advisors, nurse practitioners, MD, radiologists, RTs, physical therapists, everyone working together to make sure we're providing the best care possible. We have very specific order sets, a lot of training for our nurses. They're NIH certified, and we're constantly offering a ton of classes to make sure that they are prepared to take care of this population.
Yeah, I think that's a good thing to mention, because when we're talking about the different types of patients that we see and being trauma, being stroke, being cardiac, there are a lot of extra certifications, kind of alluded to that, but the NIH stroke, ACLS, BLS, PALS, trauma courses, all of those things we do to try to prepare our nurses to be prepared to take care of that type of patient, but we also teach those classes on our own. So it's not something where we're like sending you away to go take a class. We are instructors for that, right? So we're teaching our own and trying to create this program that everybody is involved in, that they know they're instructors, that we're really building it to make sure that it's how we want it to be. Yes.
And there's a lot, like she said, yeah. We have SCRN, it's a certified stroke certified registered nurse, and then we offer ENLS, we offer TNCC, and CBMS ICU. There's also a lot of courses that are offered as well to ensure that, like I said, that you're ready to go.
And Suzanne and Kyrie, to a certain extent, you alluded to the fact that there's CT, there's X-ray techs, there's respiratory, there's physicians. Can you kind of talk, Kyrie, I know that you do in emergency departments a tour of kind of all of the physicians, departments, the lab, right, that are all kind of working in this collaborative structure to maintain those statuses of trauma center, of a stroke center?
Sure, there's a lot that goes into that. In just housed within the ER alone, we have unit secretaries, EMTs, paramedics, nurses, There's practitioners, PAs, physicians. There's x-ray housed within the ED, ultrasound, CT scan, EKG techs, registration personnel, so people that actually like get names and insurance information, that's a big part of it too. So yeah, it's kind of a combined effort. If we have things, for example, if we have like a pregnant patient that comes in as a trauma alert, we would call the labor and delivery team, and they would come over from labor and delivery to the trauma bay and ensure that baby looks okay, et cetera. So we're able to kind of pull those resources from across the house when we have patients that require that level of care.
All right. Thank you. So I am glad that we defined those fields. I now want to know why both of you chose these fields.
We talked about this earlier. In all honesty, why I got into nursing because it's something that my grandma did, and she discouraged me from going into nursing because she was a home health care nurse. She was a teacher, clinical instructor, and so she was very heavily involved, very emotional person, right? And I tended not to be. And so from her mindset, she was kind of like, this is not the field for you, right? But some of those qualities lended me to be great at ER and trauma, right? Because you have to be able to separate yourself sometimes from those emotional situations. You have to be able to not let some of that emotional stuff cloud your judgment when you're taking care of a patient. And so I did it anyway, even though she advised me not to. And I think by the end, she was like, okay, you're right. Like I would have made a terrible trauma nurse, right? But when I was actually applying to TMH, I had never been in the ER before. I had done my preceptorship actually on Wachter Neuro ICU. And I thought that's where I was going to go. And then the ER called me back first. And so I was like, yeah, sure. Okay. They offered me first. I'll go there. Sight unseen, had never been down there. I was just like, okay. And it turned out to be awesome and the greatest thing that ever happened. It was where I was supposed to be, and I just didn't know it. So highly recommend visiting the ER if you're interested.
Awesome.
It's funny she says that because my parents also tried to convince me not to go into nursing school.
Really?
Nursing was a second career for me. I had for sure missed my calling, and I really did. I loved nursing, but they tried to convince me not to go into nursing.
My siblings are all nurses, and I told everyone growing up, because they were older than me, I'm never going to work in a hospital, and then here I am. So, what about you, Suzanne?
I chose critical care because they have an incredible support system. They truly made me feel comfortable from the moment I walked in the door. I was lucky enough to have my preceptorship in CICU, and I fell in love with it from the very first day. I loved learning about everything about my patients. I love getting to know their families. I love just the incredible support system from physicians to pharmacists to the staff, and how everything is right there at the touch of your fingers if you need help or assistance. And they really made me feel like that was my home right away.
Nice. So you guys are both from different areas, right? So what would you say you see as the biggest difference between the ICU and the ER?
I would say the start would be how long the patients stay in our unit. In ICU, they can be there 2 days or they can be there for a year. And you are working with families a lot, which I'm not sure in the ER if you're doing as much. I would say the ICU is very particular. We're very type A. I joke that we like things clean, organized, and labeled. We want everything in place. We want to know everything about our patients. But I don't really know the exact differences. I'll let you chime in on the ER.
I would say the ER is very different than that. Most of the people down there thrive in chaos, right? And so being able to find those little like strings to hold on to or pull to what rabbit hole you're going to go down right now. There is no labeling. I shouldn't say that we definitely label everything. Everybody on the call, everything is labeled. But it's a much more,
it's a different labeling system.
You know what's going on and you have everything kind of sorted out in your head, but it might not look that way on paper, right? It's kind of, you have to do what you need to do in the moment in some of those critical situations, and you'll go back and do all the documentation later, right, to show what you did. I think another big point, like Suzanne just made, is you're not getting to spend much time with families, right? So you're not typically forming that relationship or that bond, and that's very important for some people, especially in the nursing field. People who tend to go into the nursing field are people that want to form relationships, they're caretakers, right? And so for a lot of people, it's a natural instinct to want to form those relationships, and so that can be difficult for some people. It's also one of the things that was hardest for me is you don't know what happens once the patient leaves, right? So when you're in the ICU, they're staying with you for a long time. You can see that they're getting better. You can see that they're moving down to the floor or getting discharged home. For us, we don't know. So once that patient kind of goes upstairs, you hope that they made it, right? You hope that everything that you did was worth it and that it had a positive impact and had a positive outcome, but you don't always know. So that can be difficult too.
It's like a cliffhanger every day.
Yeah, a little
You
bit.
just never know. Cool. All right. Well, what's one of the biggest misconceptions that you think you see about your different areas
I'd
that
say
maybe
one for
nurses who start kind of mention to you that, oh, I didn't expect this.
the pace is one that we hear often. I think a lot of new nurses think that it's going to be fast pace, rush, 24/7, patients coding all day, every day. And that's not always the case. We definitely have our days that it is chaos and lots of codes and everyone's extremely critical and sometimes all crumping at the same time. But it's not always like that. There's also some downtime and you really get to know your patients and, actually time to hang out with your colleagues. But I don't know.
Yeah. I think that's from an ER perspective, I would say that's true too. I think people go into ER trauma expecting that it's always emergent patients and it's always trauma all the time. And so there's a lot of explaining to people on the front end or trying to set the expectation that it's not trauma all the time. You're going to get 5 traumas at the same time, and then you're not going to get a trauma for 5 days, right? And so it fluctuates like that. So you have to be willing and expect that you're going to get people that shouldn't actually be in the emergency room, people that are probably should have stayed home or gone to urgent care, gone to their primary care, but also realizing that they may not have primary care, they may not have access to care. And so the ER ends up being that site for them. And we have to treat them the same way that we would treat the trauma patient or the emergent chest pain patient, et cetera.
Another misconception I thought about too, and we hear often in interviews, is nurses want to come to the ICU because we have 1 to 2 patients, and it seems like a much lighter load, which is not the case. 2 patients in the ICU is a full load, can keep you very busy and running all day. Not always, but 2 patients can be a lot in the ICU. So they think that they're coming in and, I'm only going to have 1 to 2 patients. It's going to be a much easier shift, but there is a lot to do with those patients. So 1 to 2 or possibly 3 patients is definitely a full load in the ICU.
Yeah. It sounds like that's kind of one of the similarities even is that the pace it can fluctuate just on a given day. And that's not kind of the expectation coming into these adrenaline heavy areas, right? So I want to go into maybe some of the differences. And Sissy Jumper actually asked, what are your ratios both in the ER and in the ICU?
In the ICU, we like to call it like a 1.5 ratio. So it just depends on the acuity of your patient and what's going on. You may only have 1 patient if it's like a CRRT or an open heart, or just depending on what's going on with the patient. Or you may have 2 patients if you have 2 stable ICU patients. We do always have a charge out of pattern as well. So that's kind of where we get the 1.5. So they're rotating and helping with flow and going around to help you as well to settle in your patients as they're coming in. And then in our intermediate care unit, it is a 1 to 3 ratio, also with a charge out of pattern for the majority of the time, and then 1 to 3 every day.
I would say typical ratio is 1 to 4 in the ER. But like Suzanne said, if you're in a situation where you have a more critical patient, for example, if a trauma patient's coming in, that's 2 nurses to 1 patient, right? So that's a way mismatched. But it kind of, we work in a pod system in the ER, so it's a more of a team approach. So the goal was for everybody to have a 1 to 4 ratio, right? But if I'm a nurse in a pod and I get a critical intubated patient that's on multiple trips and I'm trying to figure out or get the patient settled, then those other 3 patients might be shared between the other 3 nurses that are in that pod for that until that patient is settled, and then I can take those patients back, if that makes sense. So that it's, you have an assignment, but it's not that's your patients and nobody's going to help you, or not like you're on your own. It's very much a team approach, and moving those patients to the most appropriate nursing resource at the time, like who has the most bandwidth. And so you might have 4 right now, but I might give you a 5th patient for a little while if this is an easier patient, while somebody else gets caught up on the higher acuity patient, if that makes sense.
And same with ICU, it's very much a team approach. So if we have to make adjustments and assignments, we do throughout the day based on the acuity and what's coming in.
Nice. All right. How long are patients in your care in both areas?
For us, it can be, like I said earlier, 2 days to sometimes they can be there for a year or 6 months. It just depends on the patient. We don't have many that stay there that long, but we do have some that stay there that long. Most of the time it's, a few days, few weeks, but it just varies depending on what's going on with the patient, depending on how critical they are.
From an ER standpoint, average length of stay across the house is 3 hours. But again, that's sometimes it's 60 minutes and sometimes it's 24 hours. If we have backup of if the ICU is full and there's no ICU beds and there's an ICU patient in the ER, then they're going to stay in the ER for an extended period of time until Suzanne and her team can get somebody out and we can move that patient in. So it can extend if there are backups within the organization or with throughput, but typical average is 3 hours.
Okay. What are the schedules like? Do they differ much?
For ICU, yeah, very different. It's definitely 7 to 7 every day, day shift, night shift.
We actually talk about this frequently when we're talking about workload indicators and stuff. But anyway, yes, inpatient world tends to be 7 to 7, 12-hour shifts, 3 shifts a week, right? ER is kind of all over the place. There's a 7A to 7P shift, a 9A to 9P shift, 11A to 11P shift, 3P to 3A, 7P to 7A, and everything in between. So there'll be times where we do 8-hour shifts, 4-hour shifts. It kind of depends on what the need of the department is and what day of the week it is. For example, we know Monday is going to be a heavy day. And so we upstaff on Mondays, right? But we don't need to upstaff on Mondays for 16 hours. We only need to upstaff on Mondays for 8 hours, right? So we might have shorter shifts or different shifts on certain days, depending on what the need of the department is.
Nice. I think hopefully that answered Caitlin's question there. And Sissy has another question of, do you have an ER hold nurse available once the admission orders are in, or is it still the same nurse caring for the ER patient?
So it depends on what's going on in the inpatient unit. That's a good question. So ultimately the ER is still responsible for the patient, right? Because they're in our unit and they're in our care. If we have a situation where there is an available nurse on the inpatient side, ICU, typically from our inpatient float pool, then they would come down to the ER and take those patients. So we try to, if we have that available to us, then we'll try to cluster those patients, admitted patients that are holding together, and have that float nurse that's coming down to take care of those patients go to a specific area so that they're not running to 3 different places in the ER to try to take care of patients. But yeah, we try to do that always. I can't say that every single day there's an available float nurse to come down. And in those cases, the ER nurses are still caring for those patients. But I will say that from knowing what national standards look like, knowing what holding patterns look like across the country, we do not have an issue like that, like a lot of places have. It's typically very sporadic. It usually is times of, I would say probably 2 to 3 days at a time where we have issues like that, and then it kind of levels back off again. We have a pretty good system in place, I would say, from being able to surge standpoint to try to get patients out of the emergency department, flexing rooms up and down, and we have some kind of contingency plans that we use when we're in those types of situations. So.
And the hospital is very supportive. Like everyone is alerted when it's happening, if there's lots of holds. So everyone's working across the entire hospital to see what they can do to make it better.
Yeah, we have a morning huddle call that we do, and we kind of give out it's like a State of the Union address, like where are we at, how many holds do we have, what is our priorities right now. And so it's not something where they they just kind of sit in the ER and everybody forgets about them. Like it's front and center for everybody. Everybody knows that that's a priority.
Yeah, all the departments work together.
Yeah.
So you talked about that support across the departments. What support exists for a new nurse on the floor?
In the ICU. So in the ICU, we have a ton of support. Like I said, we have a charge out of pattern. With 24 patients, this is a lot of support alone with just that one person because they're rounding to help you and rounding to help get your patients settled in. We also have the nurse manager and assistant nurse manager on the unit. They're constantly going out to help. They don't just sit in an office all day. They're out on the floor helping to see, whatever they can do to make the day better. Same with our educator. They're out on the floor helping, and they're constantly offering classes and offering support if you're struggling with a certain topic. Plus, they offer a ton of classes when you first come in to ensure that you're getting the education that you need. But you become very close with them, and they're right there to help you if you need them. We also have the providers that sit right there in the ICU with us. So if you're on day shift, they're sitting right there on the floor and you can walk right up to them and ask them questions. On night shift, they are available via call. We have the pharmacist sitting on the floor as well. So we're going to them all day long with questions. We have RTs on the floor. They're helping with the vents and BiPAPs and everything respiratory related. There's also, like I said earlier, physical therapists. There's just a ton of people on the floor all the time there to help you. So yeah, a ton of support in the ICU.
Similar in the ED, I would say there in each pod, there's a pod leader. So there's kind of like it would be similar to a charge out of pattern on the floor, right? Except that there's multiple mini units within the ER, right? So there's a pod leader that's kind of helping facilitate the flow in the patient care and delegation within that individual pod. There's also a charge nurse that's on the floor that's helping facilitate stuff between all three units and EMS that's coming in, et cetera. Two nurse managers in the ER. There's the providers as well that are there. We also have nurse practitioners and PAs. So it's typically one nurse practitioner, PA, and one provider in each pod. So
I forgot that piece.
You have like I don't want to say a backup, but you have that kind of like person you can go to if there's an issue. And having worked at other institutions, I can say wholeheartedly the provider teams that we have in our areas are great.
They're incredible.
They're very helpful. They are willing to teach. They're willing to partner with nursing. And that's one of the things, honestly, that's kept me at TMH.
Yeah, I would agree. I have a lot of their cell phones. If there was an issue that happened, I feel comfortable texting or calling. They are extremely supportive. And I forgot to mention them as well. We have the trauma team on the neurotrauma floor as well. They actually have an office on the floor, and their PAs and nurse practitioners are there as well as the pulmonologists. Their nurse practitioners also sit on the floor. So we have them to help us with really anything that we need. And we're all very close with the entire team.
Nice. Sounds like there's a lot of support. I'm sure it's still probably really overwhelming for a new nurse. And they're probably learning a lot of different things. Suzanne, is there like a specific onslaught that they have to learn in the ICU?
There is a lot to learn in the ICU, a lot, but we're not going to throw you to the wolves, as soon as you get there. We start off with a lot of classes, hands-on classes. You learn to work with our equipment. They kind of give you cardiac trauma, all the different classes as well to kind of help support, additional information that you would have learned in school. And our orientation is about 14 weeks. You're getting those classes throughout. We also have a didactic course that goes over charting, and we have everything else included. Mock codes throughout to offer, support. But yeah, there's just a ton to learn from the beginning. So, but from the very beginning, we're offering a ton of classes. But we also don't expect you to be able to take all the specialty patients as soon as you get off of orientation. So even though you do have a lot to learn, we try to wait till you're ready to start taking those specialty patients and kind of gradually, get you there by, like I said, lots of classes, and you kind of practice on orientation. And then after kind of getting used to taking care of 2 stable ICU patients, you grow to the more advanced, more critical patients.
Yeah. Sounds like you have to really be ready to study.
A lot of studying.
So I got an interesting question from someone that's currently doing their nurse internship at Bixler. This is Autumn. She says, I absolutely love my experience, though, I will admit the one thing that I do feel I'm missing is the opportunity to truly get to know the patient and or their family. In the ICU, do you generally find that spending so much time with the patient and their family adds to the positive experience of nursing, or is it found to lead to more burnout?
Um, that's a difficult question. You know, nursing's not always rainbows and butterflies, but there are a lot of positive things that come out of getting to support the family. I truly enjoy getting close to the family. What drives me is to make others happy. It really is. And so, you know, if I can try to help in their most vulnerable moments to try to get them through that, I think it helps to not be so burned out. That there's also a lot of challenge that comes with having to work with families because, again, they're in a very vulnerable state. They can be very frustrated and angry just because they're overwhelmed with the emotions that are coming their way. So you have to be able to remain calm and you know, they may be yelling or just frustrated. So that can, you know, lead towards burnout. But you just have to, you know, always look at it as they are going through a lot. And if you kind of plan your day around that of we're here to support, we're here to make it better. So even if they are frustrated, you're just there to support. I think it always helps with not being so burned out. You just have to have that view on it because, you know, if someone's yelling at you, you're going to be burned out. And you're going to, you know, you need to expect that these families are coming in frantic. So you kind of got to be prepared to deal with that. Does that answer the question?
I think so. I think it sounds like something that too that you would look for maybe in a candidate, is remaining calm under pressure. Are there other traits that you look for, you know, in a candidate whenever you're doing your hiring process?
We're definitely looking at personality, you know, being able to stay calm, being able to work well with others, working as a team player, not coming in knowing everything because you don't know everything when you come in. You have a lot to learn. But yeah, just someone that's, you know, can easily get along with the team and work well with others, can critically think, move fast, be willing to, you know, go home and learn. And
Yeah, I would say similar from an ED perspective. I feel like it's similar. Critical thinking for sure. People that can prioritize situations, right? They can think through like 3 steps down the road. This is what's going to happen, and I need to prevent that now so we don't get to that point. Or I need to, you know, I've got a chest pain patient that I haven't seen yet, but I also have a med due in this other room, but I know they're stable. Which patient do I go to first, right? So I think that prioritization is very important. And some people that inherently comes to them, and some people it's more difficult and they have to work at it. So I try to find people that have some sort of, I don't expect anybody to be perfect, right? I expect questions. I encourage questions, right? If you're the kind of new grad where you are overconfident and you think you know everything, that's a problem, right? That's a red flag to me.
Huge.
Because that means you're not going to recognize something or you're not going to ask for help when you need it. And so we could potentially end up with a bad patient situation because you're overly confident about what's happening. If you're asking those questions, if you're, you know, seeking out guidance, I don't care if you think it's a stupid question, ask it, right? Because the goal is that we're doing the right thing for the patient. And even if you're recognizing something and you're not sure, like this just doesn't seem quite right to me, or something seems slightly off, come get somebody else, right? There will be another nurse, there will be a provider, somebody that has more experience that will come lay eyes on that person. And I can't tell you how many times we've had new grads that have done something like that. Like there was a patient that was having a stroke, right? But it was just slight. It wasn't something that you would notice, like their full right side was, you know, but the way the lady was speaking was just a little bit off and she was kind of off balance. And the person recognized that, hey, this isn't quite, I can't put my finger on it. I don't know what it is exactly, but it's not right. And so when you're that kind of person that can recognize that and go get somebody else,
right,
then we're intervening and we're recognizing those things and getting the patient the right care.
I would 100% agree with what she said. We don't expect you to know everything, but we do want you to be comfortable asking questions and get along with others so you can go up and ask the questions when you need to and ask providers. So yeah, 100% agree.
Yeah. Caitlin asked, after starting in the hospital, how long would you say it took to feel used to the speed of things and feel confident in your skills?
I think it takes about a year. You're out and functioning on your own within 12 to 14 weeks, but it really takes about a year before you really feel comfortable in your own skin of what you're doing. But you have a lot of support that first year that's kind of helping coach you along. But it does take a while to get used to all the equipment and all the drips. And there's a lot of providers to get to know and, a huge team to get to know. So it does take a little while.
Yeah, for sure. I would say about that year mark. I think it was about that year mark where I left the day and I was like, I did everything. Like I didn't have to ask anybody for help. I had all my patients taken care of. All my meds were on time. All of my, everything was done. I felt good about it. Like all my admitted patients, I had them in their gowns. I had their IVs done. I had their fluids on. I was like, I've done it. I have made it, But I would say that 6-month mark is where you're like drowning and you're like, why did I choose nursing? This is the worst decision I've ever made in my life. And then if you can make it through to that year mark, then you're usually pretty good.
And your team knows that that's how you're feeling. They tend to try to come in and help you a lot through that, those first few months. They don't expect you to be perfect when you come off of orientation. They very much know what it's like, and they're very supportive, and they know the first year is kind of rocky. So don't feel pressured to come in and just know everything as soon as you get off of orientation.
Yeah. So this kind of feeds into that. Can both of you, maybe share a challenging day or days, so that everyone can kind of get a glimpse inside what it's like to work in those units?
I'll just give like a generalized answer versus a specific day that I faced. But you can have a very challenging day where you're, very busy with one patient, and then you have another patient roll in the door that, needs your undivided attention. It is very important to be able to, reach out to your teammates and ask for help. But there are days that you are running all day long with helping with bedside procedures, and you're titrating drips or having to assist with getting meds so the providers can intubate your patient. I mean, it just depends on what's going on that day. But, some days can be very, very busy, just depending on which patient's rolling in the door. Or you may be fine for a few hours and then get really busy the second half of the day. But again, it all depends on the day, because some days you can have lots of downtime. Other days you can feel like I came in, I got report, then I gave my meds, and then I got another patient, then I had to get ready for the OR, and then I had to prep this one for a central line, and then I had to come over here and help with getting meds for intubation. And so it just depends on the patient, on the day. I mean, there's a huge variety every single day of what your day's going to look like. So kind of challenging question to answer.
I would say probably the worst day that I ever had as a nurse. I was working in the trauma bay, and we got a call. There was a trauma coming in. It was a car accident, and the patient was coding, and so we got everything ready. We had the whole team back there. Everybody was ready to go. The patient gets there. We get pulses back. We're trying to get him stabilized so that we can go to CT, loses pulses again. We start resuscitation again. It was kind of this back and forth, and we couldn't ever get him stable enough to figure out what was wrong. Like where was he bleeding from? What was the injury? Because on the outside he looked fine. And so it was like, what is torn? What is broken? What is happening? And we couldn't ever get to the point of even figuring that out, right? We couldn't stabilize him long enough to do that. And finally, after an hour and a half of doing that back and forth, we finally called it. We're like, we can't do it anymore. And got all of his everything together, and I went to go get his belongings and package up his belongings, and looked at his wallet and realized that it was my best friend's dad, and had to make that call to my friend to say, hey, tried not to tell him over the phone, but I need you to come in. I have something that, sorry. But that was my roughest day. Yeah, that was my roughest day as a nurse, for sure. Sorry.
It's okay. I mean, you definitely have your days. You have a lot of rough days. I can remember my very first day. First day, walked in the door, first day, my patient coded 7 times and my preceptor went into labor and had to leave.
Oh, Jesus. Oh, that would be terrible too.
Yeah. But you get past it. I also had a similar case to Kyrie, having to tell a friend some bad news. I mean,
that's the roughest for me.
That's tough. I've actually had several cases like that where
Yeah.
I've had to tell friends bad news, and that's
That's
that-
always the worst. When it's somebody that you know, or
Oh,
like a family
yeah.
member or somebody that you know,
that never gets easier. And some days you just have a rough day because you're so busy, you feel like you just can't catch your breath, but that's okay. I mean, we all know that that's what a day in the ICU can look like, and we do try to support you and help you through that. And like I said earlier, not every day is like that. You do have those days, though. You do have the days where you lose patience and you're crying your eyes out, or you can't breathe because you're so busy, or you just feel like you don't know what you're doing, and you don't really want to ask because you've already asked 20 times that day, but you still have to go ask, and everyone's still going to jump in and support you. But yeah, dealing with deaths was something I struggled with at first in the ICU. I joke that I cried for the first 6 months. I did not cry for the first 6 months, but I did cry a lot. And I talked to my preceptor and said, I'm not sure I can deal with this much death. So, those things can be challenging, but you do get past it, and you realize that everyone else is dealing with the same thing. And like I said, the teams are so supportive. They help you through those moments.
yeah. I would say typically I'm the one that's able to kind of like disassociate, and it's usually not an issue for me. Like I'm usually very good in those situations, and I was in the moment in that situation, right? Like the family thanked me profusely for weeks to come, that they were so glad that I was there, that I was able to help coordinate for things for them. And it meant so much to them. And I was fine in the moment with them there, right? But then after the fact, I'm not okay,
Yeah.
right? So it's also about like, how do you find that balance, right? Like how can you figure out how to maintain for what your patient or your family needs in that moment? And then how do you deal with it on the back end? And there has to be some kind of, Suzanne talked about burnout a lot already, but like, how do you come back, right? You're giving so much constantly. You're giving to your patients, you're giving to your families, you're giving emotionally, or trying to hold emotion in, which is also taxing, right?
Yeah.
And so you have to figure out what on the outside of this job fills your tank back up, because you can't just keep giving and giving and emptying yourself without getting filled back up to be able to give more, if that makes sense. So I think it's very important for new grads, especially very early on, to figure out what those things are. Who's your support system? What things do you do that bring you joy? Is it vacations? Is it working out? Whatever it is, like you have to figure out your thing so that you can balance, right? You have to have that like give and take.
Yeah.
It's also helpful to have friends in your unit.
Yeah.
Because you may go home to your husband or your family members and they don't quite understand what you went through for the day. You can tell them, but they're not going to quite understand. So having friends within your unit is extremely helpful, because you can talk back and forth and they really get it. They know what you're going through.
Yeah. Agreed.
You're getting a lot of love in the chat.
Great. Most embarrassing moment of my life.
Sissy says, you're the essence of humanity. I've been a nurse for 12 years. It's not always easy, but it's so rewarding, and gives you a hug. And Amelia asks kind of a similar question in the vein of encountering so much stress and so much death. Do you have any tips on how to handle extremely stressful situations? And let's say this is one where it's like it's in the moment. It's a stressful situation in the moment.
TMH has actually done a phenomenal job with that. They have what they call Code Lavender, which we call them quite often in the ICU. But they come in and they bring you coffee and tea and all the lavender smells, and bracelets, and play music, and you can go in the break room and kind of just debrief, which sounds silly, but it's actually very helpful when you're having an overwhelming moment and you just kind of need your team in there with you, because it kind of brings everyone together, and nothing better than eating chocolate when you're stressed out. And we also have like respite quiet rooms that you can go to as well if you're overwhelmed. They have like little massage chairs and just kind of to have a quiet moment. So I think TMH does a pretty good job with that.
I think everybody, I would say from a teamwork approach, sometimes you have to be an advocate for yourself, right? Like I am, as opposed to what you just saw, not typically a very emotional person, right? And so it was difficult for other people to see when I was overwhelmed or when I was stressed out. And I had to learn how to say, hey, I need a minute, or like, I need you to give me 10 minutes. I need to go take a lap and walk outside for a second. You have to be able to advocate for yourself for your needs in those situations as well. In those moments where it's like patients are yelling at you or it's a stressful situation, I hate to say disassociation because I feel like that gets a negative annotation to it or connotation to it, but there are times where you have to just have tunnel vision. Like you have to be able to block out the other things and figure out what needs to get done in this moment and not stray, right? Like not get pulled in by the family member, not get pulled in by the emotion. You have to like, this is a critical situation. I have to be able to put all that aside for right now, right?
And I feel like that kind of takes time. That's not to be expected when you're a fresh new grad right off of orientation. I think it took me probably a little over a year to get there. I remember my patient lost a baby and I was flooded with tears. I could not hold back. And my preceptor said, now is not the time. You've got to learn to hide those tears and go in there and support them. And she was totally right. I mean, it took me a while to get there. But in that moment, I thought, I could never do that. This is horrible. I'm heartbroken. I just want to fall apart. But with time, you do learn that sometimes you can be more supportive and really help the family if you're not falling apart yourself. And so with time, you get better at, being able to know when you need to step away or know, when you need that extra moment. And also to know, when is the appropriate time to fall apart and not.
Yeah.
But it takes time.
What would you say is your biggest advice for someone who enters your specialty?
I'll let you start.
I would say the biggest thing for me, for anybody that comes into the ER, anybody that goes anywhere, let alone the ER, you need to shadow places. You need to get a feel for the staff that's on that unit. You need to talk to the manager, introduce yourself to the manager and get a feel for what they're like. Talk to the staff that's on the unit. I am a big advocate of going to the area in which you want to work,
Yes.
right? It's not helpful to anybody if it's not the right fit. And right fits is not anybody's fault, right? And I think that's a misconception people get a lot of times too, is like, well, you're telling me I'm bad or I'm not good enough to work here, right? And that's typically not the case, right? Typically it's a mismatch of what your strengths are and what that unit needs, if that makes sense. And so it's important to find the area in which you're able to contribute and that unit is able to like support and give you what you need back too. And I think a lot of that you can tell when you're doing those shadow experiences. So I highly advise any new grad to go to the area in which you are interested in working, talk to the people in that area, get a feel for what it's like.
In addition to shadowing, if you can handle the load of like school and work, if you can get a job as a nurse extern or a monitor tech, it is extremely helpful coming in. Already knowing where everything is, knowing what the team is like, knowing the providers that you're working close with, it just really helps to alleviate a lot of that stress when you're first coming in. You already have friends within the unit. They can help you along the way on your orientation. And just having to run and grab things quickly, you already know where everything is.
Yeah.
So if you're at a place in school that you can take on a job, because not every, I know some semesters are extremely busy, but if you're at a place that you can take on that job, do so. And we tend to really work with the students to make sure that we work with their schedules because we know what a benefit it is for us as well as the student. I personally think that, those nurses are so much stronger when they come off of orientation just because they really can focus on the important things versus having to focus on all the small things.
Completely agree with that. Like, it's one thing to learn how to take care of a patient when you're in a comfortable environment and you know the people around you and you already feel supported and you already know where everything is, right? It's a totally different thing to learn how to take care of a patient when you're in a new environment. You don't know anybody. You don't even know where the cafeteria or the bathroom is. You have no idea what any of these supplies are or where they're located, right? Because there's going to be so much new equipment and patient care things that you need to learn. Like, if you already know those things, then you can truly just focus on the patient care aspect of it.
It also it's sometimes challenging to get a position in ICU and ER. They are very sought out areas. And we very much protect our own. We're very close teams. So if you are part of the team already, it definitely helps with getting a job in the ICU or ER, I would say as well.
Yeah.
We very much protect our own and we want to grow the new nurses and help them along. So it helps.
Yeah. And I would say also to that, don't get discouraged, because what Suzanne is saying is true. There's typically a limited number of spots in specialty areas, right? Don't get discouraged if you didn't get it on your first try or as a new grad, right? We try very hard to pull nurses from like med surg, for example, right? If you know that if your heart is neurotrauma ICU, their first place to pull from is going to be the neuro floor or the trauma floor, right? From a nursing standpoint for experienced nurses. So just because you didn't make it as a new grad on day one doesn't mean you're not going to get there. And you can still set yourself up to know the organization. You can still form relationships with the managers in the areas that you want to, or you want to grow into. And doing those types of things, like going to those kind of sister units, helps facilitate that. So don't give up. You can still do it.
There's been a lot of nurses that I've held onto their numbers and their information, and we've stayed in contact over a year. And then when it was a better time for them to come over, they transferred over. If they weren't quite ready for ICU, but knew it was something they really wanted, we just stayed in contact the whole time. Every few months we caught up, and then when it was appropriate, they came on over. So.
I'm going to ask David's question because I think it's kind of speaks to what we're talking about. But, obviously you say you encourage it, but is prior experience needed or wanted? I mean, we do want to, we encourage it, right? But is it necessary for the ER of the ICU?
It is not required, but it is very helpful. So we do look at it when we're interviewing.
I would say that it's not. It depends on the person, right? There's some people that can handle learning the new environment, learning all the new equipment, learning how to do patient care all at the same time, but not everybody can. And so for those types of people, and I feel like people know that about themselves for the most part. Like, am I that person that's able to prioritize or, juggle these 14 different things at the same time? Or am I the kind of person that I need to come home and I need to read this chapter and I need to take practice questions on it and I need to do flashcards? And if you're that kind of person, then going straight into a critical care environment is probably, you're not setting yourself up to be successful, right? And we want you to be successful. Right. Even the specialty areas want you to be successful, right? And so if you can get to, okay, I've learned the organization, I've learned my basic patient care, I can start an IV, I can give meds. Now I can go and focus on just learning the critical thinking aspect of it, that prioritization, like I was talking about. Then that can be a lot easier transition for a lot of people. So it depends on the person.
Yeah. And it definitely can make the transition easier.
Yeah.
But we also have a lot of nurses that are very successful that start in the ICU right out of school.
I mean, both of us were new grads that started in specialty areas. So it can be done for sure.
And it is all the time.
Yeah. Do your areas require or encourage specialty certification?
We don't require.
Go ahead.
I was going to say we don't require them. Anything that's required by TMH, we offer. So if it's like the trauma courses or certifications, ACLS, PALS, those types of certifications, then we offer them. We encourage people to get their specialty certification. So like in the ER, there's just through ENA, but it's not something that we require you to do. We encourage you to do it. We will pay for you to take the test. We do what's it called? Reimbursement. For the cost of the test if you're successful in taking it. And we do give a differential for those that are certified. So it does give you a little boost financially.
I was going to say that too. Most of the time the nurses are asking for it because it does give you a boost in pay, and it's courses that we offer here to help. And, if you're working in, say, like Proctor Neurotrauma ICU, you may want the additional support of the classes. And then knowing that you can take a test that you're going to be reimbursed for and get an increase in pay, a lot of the nurses want to do it on their own, but it's definitely not required. But we offer a lot of support with that. We also have some online courses that you can do to help if you want to get like your CCRN. And we have a lot of books and resources. So most of the time it's the nurses reaching out, wanting to do it.
Yeah. It does seem like TMH is just a very encouraging place to kind of support that professional growth and doing that through certification. Can you also speak to maybe the BSN? Do you require or encourage a BSN?
We encourage it. It's not something that we require. We do again, tuition reimbursement. So if you're a nurse that's working in one of our units and you want to get your bachelor's degree, we do tuition reimbursement to help you get there.
Okay. And
And
then
then there's also a differential once you have your BSN.
And your MSN.
Chrislanda asks, would being an LPN also be fine?
From an experience standpoint, it's definitely helpful.
You mean as previous experience or coming in as an LPN?
I think coming in as an LPN.
Unfortunately, we only hire RNs in the ICU.
Yeah, and in the specialty areas we require RN, we do have LPNs in our med-surg areas. So if that is, I would encourage somebody to go work in med-surg and do their RN, right? And then that's kind of giving them that background of learning the organization, learning even the charting system, like that all translates across all of the areas, and you can get your RN while you're working, and then transition into the critical care areas.
And if you work for 90 days with TMH, they also do tuition reimbursement for those higher degrees in nursing.
Yes.
Not up to the BSN, which is another question that we got. This person asks, it's amazing, I guess, the scope of ICU and ER. I'm thinking of relocating next year to Tallahassee. I have over 10 years of nursing experience and will be starting FSU in August for my NP. Does TMH offer any kind of tuition reimbursement for the doctorate level? We've had a little bit, but not a complete system, right?
Yeah, so we don't offer anything currently for nurse practitioners. And typically that's what people are going to DNP school for. We did start a cohort. We have our first cohort that's starting in August for nurses, executive health systems leadership track DNP. We have a cohort in August that's starting. There's 10 of them that TMH got funding from the foundation to help support their education in doing that. We're providing that to people who are currently leaders at TMH who want to grow in their leadership at TMH. And so it's a way that we're giving back to them to help kind of boost them to that next level, but currently not doing that for nurse practitioners.
We've got a couple minutes left. We have one question that I feel like might have a complicated answer. Suzanne, if you could answer it maybe quickly. Do you have any insight on the difference between NICU and normal ICU experiences or workloads?
Babies are smaller.
Yeah, I don't know if I really answered that one. I've not worked in the NICU. My son was in the NICU and had a phenomenal experience with our NICU team here at TMH. And they seem to have, that 1-to-2 ratio similar to adults. But other than that, besides how phenomenal they are, I can't really give a difference because I have not worked in NICU.
Okay. So I'm gonna kind of give out a last call for questions, and then also if Suzanne, Kyrie, if you have any parting words.
I'm not prepared for parting words.
I did want to encourage the nurse that's coming back to school to give us a call. We have a lot of nurses that are in ARNP programs or preparing for CRNA or flight nursing, and we're very supportive with that. So give us a call.
Nice.
Agreed.
All right. Well, thank you to Suzanne and to Kyrie, and thank you to everyone who joined our call. I really hope that this was a helpful discussion that maybe helped give you some extra insight and information into making your decision as you approach graduation. As always, TMH is really happy to answer any questions and to serve as a resource for you in your career. So please, if you're considering sticking around Tallahassee or moving to Tallahassee, definitely stay in touch with our TMH recruitment team. We will be happy to help you along. Thank you again.
Thank you.